So, good morning. Welcome to all of you for this second topic in Oman Hall. What is new in pediatric ophthalmology? So, for this session, we have got an esteemed guest speaker, Dr. Sumita Agarkar from SN Chennai. Madam is currently the Director of Paediatric Ophthalmology at SN Chennai, and her contributions to the cause of pediatric ophthalmology are immense, all of you know. And if we start describing her, so like in the last session, like Mohan Rajan sir was described, if we start describing, there will be no end to it. So I think all of you, many of you might have gone through the current AAOS Times book. So if you haven't gone through that, please go through it. The first topic in that AAOS Times news book, it's not a newsletter, it's a news book, and that conversation with the legends. And the legend discussed this time is Madam. So one of her favorite fellows had an interview with her, and if you go through it, you will get a glimpse of what Dr. Sumita Agarkar is to pediatric ophthalmology. So a warm welcome to you, Madam. And in this session, we have also got our own Dr. Rashmi Bhaskar talking on newer things in amblyopia, and Dr. Chaitanya Warrior, she is talking on newer things in visual assessment of children, and Madam Sumita Madam will be talking on the myopia control glasses, which all of you would be eager to hear, and also the low dose atropine and myopia, which though it's in the pediatric ophthalmology regime for quite a few years now. Where do we stand as of the pediatric ophthalmology? These are the two topics which will be covered by Sumita Madam. So as for myself, I think though it's titled What is New in Pediatric Ophthalmology, in 55 minutes we will be able to cover a minuscule of what is new in pediatric ophthalmology. And apart from the three topics being discussed with the three guest speakers, I think I will touch upon the few other things which are new in pediatric ophthalmology. So the in thing in pediatric ophthalmology, if you want to discuss, would be the gene therapy. So we have FDA approval and FDA guidelines in gene therapy for RP, Leber's conjunctival and other a few inherited retinal disorders. But the problem is, though we have gotten railroading into conditions like RP, even though we have gotten FDA approval for a few drugs in gene therapy, the good thing is that we have got an initiation into the gene therapy. But the other part is that even now the FDA approved drugs, they cater only to a small percentage of RP patients who have got a specific genetic mutation. So it doesn't cover the whole RP spectrum, but anyway, we know that we have something to offer. And the results of gene therapy, as for we have done, it shows that younger age children who are into this therapy, they get better visual improvements. But as we stand now, we doesn't rule out the procedure in adults. And the Pediatric Eye Disease Investigator Group Network, which has done a lot of studies in the pediatric eye disease segment, and they have evolved a lot of changing patterns in the treatment of amblyopia, strabismus, childhood glaucoma, congenital cataract, NLD obstruction, anti-VEGF in ROP, etc. So if we look at where do we stand in ROP as of now, the recent criteria for predicting ROP for neonates with different birth percentiles have come in, and also the international classification system of ROP, which is in place, has been updated. This updation has happened because of the newer things that we have found in ROP, updation we have got on ROP, and also with more of anti-VEGFs being given, there is a slightly modified changing pattern in ROP that has come in. So all this has led to an updation in the international classification. And also in ROP, there has been an accelerated use of telemedicine in almost all the states. If you look at what is new in strabismus, traditionally when we talk about an extraocular muscle and its movement, we talk about the extraocular muscle starting from its origin to insertion, how does it act. But the active pulley hypothesis, which has been put forth by Miller, Demmer, Clark et al., it has been found that they have proposed that there is an connective tissue network which is called as a pulley, and it has been found that it has been hypothesized that the extraocular muscles have got an orbital layer and a global layer. And they have hypothesized that the orbital layer inserts into the connective tissue pulley rather than into the globe. So understanding this pulley hypothesis or getting involved into this pulley hypothesis, we have got, if we understand the this pulley hypothesis and if we work upon that, we have found that the physiology as well as the pathology of the extraocular muscle action and many of the pattern strabismus things have changed a bit, and this is being updated as of now. And another thing in squint, it has been found that the injection of bupivacaine, which we use as a local anesthetic, if you inject bupivacaine into the extraocular muscles, it induces a cycle of myotoxicity, degeneration, which goes on to regeneration and hypertrophy of the muscle fibers. So the net effect is, when you get in hypertrophy of the muscle fibers into which you inject bupivacaine, what happens is the effect produced is something like the resection that you have done on the muscle. So it just pulls on. So in a case of small angle esotropia, if you inject bupivacaine into the lateral rectus, this resection effect produces small corrections. So this is something which is rather new in squint correction, and Scott et al. Proposed that bupivacaine injection into the horizontal muscle which you plan to resect and Botos injection into the horizontal muscle which you plan to recess will correct reasonable amounts of squint. This is something called as an chemical resection decision in a squint. And this slide again is also about a word about genetics. Why genetics is important? Because most of the other things we are rather taken care of. But genetic and inherited disorders, we are still at a loss. So most of the inherited genetic disorders, not only in the eye but otherwise, they are called ciliopathies, and it has been found that nonsense suppression therapy. So all these genetic disorders, they happen because of abnormal mutations, nonsense mutations. So if you have gotten therapy targeted at these nonsense mutations, which suppresses this nonsense mutation, you can have a cure for or treatment for these ciliopathies which produce inherited retinal disorders. So we have gotten better understanding of the neurophysiology of vision, and we have found that in nystagmus, a simple surgery like tenotomy and reattachment of the muscles in the soginal site for nystagmus produces results, and selective endothelial removal for congenital corneal opacification is coming up in a big way. Even neurotization of the anesthetic cornea for corneal hyposthesia and aesthesia. But in spite of the advances being made in the diagnosis, treatment and understanding of the visual system, the advance to this advanced treatment care will be maybe in 1 or 2 decades. Still we will be, because of the cost as well as the universal availability of these newer things, we may not be into these routes in a big way in the coming few years. Maybe in 1 or 2 decades we will be into this. Thank you.